Good evening, everyone. My name is Meryl DaCosta, and I'm a pelvic health physiotherapist at Registered Physiotherapy in Georgetown and Acton. Today, we are doing this recording for you just based on the webinar that we were hosting last night. So, without further ado, the talk is on pelvic health physiotherapy and why it's important. So the first thing I thought we would discuss is maybe some of the common misconceptions that we do hear just in social media when we're out and about with friends and family, actually not doing that right now, or also in the clinic. Um, so one of the big things we hear is it normal to leak urine as we get older? And as we age, and that is definitely very common, but it is not normal. And definitely know that with pelvic health physiotherapy, it can be resolved. Is it normal to have urinary leakage after childbirth? So again, it's another one that is very common to have, and usually will happen within the first 6 weeks of childbirth, just because of the weight of the baby that we've carried. So again, it's very common, but it's not normal, and again, can be treated effectively. Is it normal to have pain with sexual intercourse? So again, this is very common, especially after childbirth and sometimes as we age. It is definitely normal to, or excuse me, common to have pain with sexual intercourse, but it's not normal. And again, there are things that we can do to treat it. Is it normal to have urinary leakage with exercise? So we hear a lot of people talking about when they're when they're jumping on their kids' trampoline, if they're trying to run after their kids, that they do have some leakage. And again, it's definitely common, but not normal. And again, just know that there is a lot of things that we can do to treat it effectively. And then finally, pelvic organ prolapse. Is it common amongst women? And again, yes, again, very, very common. About 50% of us in that childbearing age group will have pelvic organ prolapse. And sometimes, again, we're not even aware that it's present, but it is. Okay. And again, something that we can do to take care of that. Okay, so what we're going to talk about tonight is to understand what the core and the pelvic floor muscles are. We're going to take a look at what bladder function is. We're going to look at the epidemiology, or like I like to call it, the stats. We'll look at signs and symptoms of pelvic floor issues, talk a little bit about the pelvic floor assessment and what we do. Okay, we'll look at the conditions treated, and we'll look at treatment. Okay, so the core, when we think about the core, a lot of us will think about just the abdominal muscles, right? And I think that's pretty common in what you see in the fitness industry. But the core is actually made up of four different muscle groups. The first one is the diaphragm, and I call the diaphragm the roof of the house. So the diaphragm is our big breathing muscle. So as we breathe in, what happens is you have a dome-shaped muscle that comes from here. As you breathe in, that muscle tends to lengthen. Okay. The next muscle is wraps around the big abdominal canister, we call it, and it's known as the transverse abdominis. Let me just move my little diagram here out of the way. So that transverse abdominis, I like to call the Spanx of the body, and it helps to provide stability to that abdominal region. Okay, the next one is the pelvic floor muscles, I should say. And there's three layers of muscles that make up the pelvic floor. So there's numerous muscles. And basically what it does is it extends from the front or the pubic bone all the way back to the tailbone. Okay, and the one that we commonly forget about is the multifidus. And these are small little muscles that are found along the vertebrae, and they span from the sacrum, or the base of that tailbone, all the way up actually into the neck as well. So those are the four muscles that make up the core. Okay. When we think of the pelvic floor muscles, we actually think about like a toned hammock. Okay. A toned hammock is something that actually, when you go to sit in, it's able to absorb some shock. Okay. It can recoil back depending on the weight or how many people are sitting on it. It's got a little bit of give to it. What we don't want is a droopy hammock. Okay. A droopy hammock is something when we have pressure or changes in movement, will actually not absorb it. It will kind of like lower down till you're almost hitting the ground, which wouldn't be comfortable. Okay, and what our pelvic floor muscles do, as we had talked about, it extends from that pubic bone. Let me see if I can find my arrow here. So it extends from the pubic bone and it wraps all the way around to the tailbone, and it kind of moves from one of the sits bones to the other sits bone. So it's almost forms like even a triangle as well. Okay, so the pelvic floor muscles are important and it provides a lot of important functions. Okay, so the first one is what they call sphincteric. So it helps to maintain our bowel and bladder control. So it's involved in the opening and closure of both the urethra and the anal canal. It plays an important role in sexual function, in that it plays a good role in terms of sensation and allowing us to have pleasure. Some of my clients will usually talk about, usually as a secondary piece, where, when they're having sexual intercourse with their partner, they may not have orgasms. Usually, and it's because sometimes that tone of those muscles is not very good. They're kind of that saggy hammock. So as they tend to strengthen their pelvic floor muscles, sometimes the added benefit of the pelvic floor physio is that they start to have improved sexual sensation. Okay. The other one of the other functions of the pelvic floor muscle is sump pump. Okay, and what this means is it helps to move lymphatic fluid within the actual tissues. Okay, one of our big functions of the pelvic floor includes the support. So what it does, it actually supports our organs, particularly the bladder, the uterus, and the rectum. And then finally, it's part of the core muscles and it helps to provide stability through the low back, hips, and your pelvis area. Okay, so when we think about the pelvic floor and the core muscles, we think about the breath. Okay, and how we know that those four muscles all work together is when we take a breath in and our diaphragm lowers. So I'm going to kind of bring my hands here just so that you can see them. What happens is as that diaphragm lengthens as the lungs fill with air, if our pelvic floor is here, what it does is it tends to lengthen, and those abdominal muscles also, I wouldn't say necessarily relax, but I would say they would lengthen as well. Okay, as we breathe out, what happens is everything recoils back and our pelvic muscles contract as our abdominal muscles engage as well. Okay, so how we think of this is as a piston. So as that diaphragm and the pelvic floor muscles definitely work like a piston, moving up and down in that abdominal cavity. And what's really important to note is that these muscles should act reflexively. They should be able to turn on and off without us actually thinking about them. Okay, so typically most of us will not have any dysfunction, right, as children. Okay, and as we get older, most of the times, most people will actually see dysfunction happen usually after childbirth or as we get older. Now, what we're noticing though is that there is a subset of that of ladies within their 20s who do a lot of, say, CrossFit and running, who are having some issues. And again, usually it's because this core breath is not working effectively. Okay, so one of the other things to really understand is how that bladder functions. Okay, and I call the bladder essentially it's like a storage tank. All right, and it's a storage tank which actually has a muscle called the detrusor that actually sits around that tank. Okay, so as you're eating and drinking all day, what happens is the bladder tends to fill with urine, right? So the byproducts of the kidneys kind of dump into that bladder. And as that bladder starts to hold more and more fluid, what happens is there's a stretch in that detrusor muscle that surrounds it. When you get to almost a cup of water, 250 mils of water, what happens is your that stretch of that muscle or the detrusor muscle sends signals to the brain to let your body know that, hey, it's time to go to the washroom. Okay, and so that's typically that first urge to go. Okay, usually when most of us have that first urge to go, what we do is then say, hey, it's time to go to the washroom. So we go and find that washroom. Okay, as we go to sit down, what happens then is our body recognizes that, all right, Meryl has sat down on the toilet, so it's time to allow those pelvic floor muscles to relax and time for me to empty out the bladder. Okay, and then that cycle goes again. All right, there's a number of different things that can cause that to to be dysfunctional. Some of those include, the just in case piece. So, we know that we're going on a long car ride. So what we do is that we go to the bathroom just in case. The problem is when we start to do that more and more regularly, what happens is that bladder starts to think that instead of waiting till that there's 1 cup of water within our bladder, we feel that it realizes that, oh, you know what, Meryl likes to go to the washroom when there's only, say, 100 mils of water in her bladder. So what happens then is that brain, when it gets to that 100 mils, it gives me that signal to say, go to the washroom. So when then you go to the washroom, you realize, oh, there wasn't a lot to go. All right. So it's really, really important that we start to recognize that we only go to the washroom when it's telling us. So why is pelvic health important? Okay, so and this is where the stats come in. So we know that 3.3 million Canadians will have urinary incontinence, and that's 1 in 4 women. And we sometimes forget that men have pelvic floors as well. So we know that 1 in 9 men will also have incontinence as well. Okay. Chances of urinary incontinence in women. So, and we had just mentioned this, that 20 to 30% of young adults, so usually below the age of 35, will have urinary incontinence. As we get into that middle age, it's 30 to 40, and then later age, it's 30 to 50%. Okay, there are 3 different types of urinary leakage. That includes stress urinary leakage. That is when we laugh, cough, sneeze, and jump. Mixture is where there is a mixture of urge incontinence and the stress. Okay, and then again, urge urinary incontinence. So that's where we feel like we've got to go and we just can't hold it. Okay, we know 50% of women at some point in their life cycle will experience some urinary incontinence, and 33% will develop regular problems. Okay, so the key factor here is to know that there is a direct and indirect cost that's associated with urinary incontinence. I was trying to look for some newer stats and couldn't find any, but in 2014, the cost was $5.3 billion. So it was probably a total of, say, if we were looking at individuals, would be about $6,000 a year were reported per year. Okay, spent on incontinence products, and we know that the average cost of pelvic health physiotherapy is about $500 to $700 a person. Okay, so when we talk about urinary incontinence, we also have to realize that there are some social consequences that can be detrimental to people's health. Okay, and usually because when people start to leak, there can be decreased self-esteem. Right, we're really embarrassed because we've leaked in our pants. We don't want our friends to know. We start to feel bad about ourselves. And as a result of this, we will also then start to get depressed. We may not be going out as much. We may be limiting how far we go. We're usually then planning as to, where is that next washroom? Are we able to stop in? And we may stop going out altogether. Okay, and as I mentioned, it impedes that social activity. Okay, and we also know that physical activity declines as well. All right, and we stop doing our typical activities of daily living. Okay, now there's a number of risk factors, and I really like this diagram. So, one of the risk factors they had in there is prostate surgery, and I think we're mainly focusing on women here. But just know, as I mentioned, that males do have pelvic floors as well. We know as we get older, definitely our muscles tend to weaken, and it can be a risk factor. We know that with pregnancy and childbirth, depending on birth trauma, because we carry babies and load for 9 months, it can definitely impact our pelvic floor. Genetics can be a big thing. There's a lot of research now talking a lot about our connective tissue and how it can impact or be impacted from family member to family member. Hysterectomies as well can also impact our pelvic health because of the change in hormonal levels. Any sort of pelvic floor injury, and that can be classified in birth trauma as well. Increase in abdominal pressure, and we'll go over this a little bit more as we kind of move through the presentation. Chronic constipation is another thing because the load placed on the pelvic floor. Intense physical effort, so lots of running, CrossFitters. Obesity is another one, and also a history of back pain as well. Okay, so some of the common signs and symptoms that we hear in the clinic include urinary leakage from running, jumping, coughing, sneezing, sitting to standing. We'll hear people talk about painful intercourse, frequent urination, the inability to hold urine, they just can't make it to the washroom, dribbling after they urinate, sensitivity at the vaginal opening, or just pain and discomfort. Difficulties keeping the tampons or the Diva cup in, feeling pressure in their vagina, and sometimes a burning or stabbing pain in the pelvic region. Okay, so conditions that we treat include urinary incontinence, so urge, stress, and mixed incontinence. We've got painful bladder syndrome or interstitial cystitis, painful intercourse, also known as dyspareunia, pelvic organ prolapse, fecal incontinence, tailbone pain, pudendal nerve variability, vestibulodina, excuse my pronunciation there, frequent urinary tract urinary tract infections, constipation, rectal pain, and rectus diastasis, to name a few. So what is pelvic health physiotherapy? So with pelvic health physiotherapy, what we do is we actually will start with a subjective assessment, okay? And typically I find with my subjective assessment, we're kind of unpacking a whole health history. So we're looking to understand, is what brought you into the clinic, okay? And what are some of the signs and symptoms that you're demonstrating? We want to understand any medications that you're taking, and we wanted to kind of also know a detailed history of any injuries that you've sustained, and also taking a look at how it's impacting your life. We then move into an objective assessment where we take a look at your low back, your mid back, your hips, and your pelvis. We take a look at how you're moving and functioning. So, we may be looking at how you move from sitting to standing, how you get up and off, a treatment table, how you roll over. We'll take a look at, what they call an active straight leg raise, where we're looking for contribution of how other muscle groups contribute to your pelvic floor. We'll take a look at your breathing. If you've had any scar tissue, we will want to see how those scars move, because those scars can also impact, how the muscles and the tissues below you move. We'll look for any nerve involvement, and then look for any sort of local contributors that could be creating some of the issues that you're coming in to see us. Okay, so an internal assessment is then also performed as we go through and do more of what we call, or think about, an orthopedic assessment, and that's to really assess the pelvic floor muscles, right? So to really understand, are you able to contract them? Are you, how strong they are? Do they have endurance? Are you able to maintain good tension and relaxation, and to realize if there's any compensations? So a number of times when people come into the clinic, sometimes they just don't know where their pelvic floor muscles are. They don't know how to contract them, or conversely, they may not know how to relax them. So they're holding so much tension in those muscles that they just can't relax them. So we try to, like I said, really look at a detailed assessment, just to make sure that that we can provide a proper treatment plan for you. Okay, so with pelvic floor function, as I was just mentioning, is that those muscles need to be able to contract, they need to be able to relax, but we also need to be able to coordinate that muscle function with other movements. So, if we're lifting our babies up, if we're loading groceries into our car, if we're carrying groceries into the house, if we're cleaning, if we're going for a run, so just a variety of different activities. Okay, when we're talking about pelvic floor issues, there's usually two states that we will see. So one where the muscles are weak, they have poor endurance and lengthened. That state is called hypotonic. The other state that we'll typically see is where the muscles are weak, they've got poor relaxation, so you're not unable to let them relax, or they've got lots of tone in them, and they're very tight. And those are called hypertonic. Okay, so as I mentioned, with hypotonicity, which are the lengthened and weak muscles, typically we'll see stress urinary incontinence or pelvic organ prolapse. With hypertonicity, those tight and weak ones, usually it's urgent incontinence. Sometimes there's urgency, frequency, hesitation, or retention. You're unable to, release the urine. We'll have pelvic pain or dyspareunia. Okay. So hypotonicity, we think of stress urinary incontinence, and this is incontinence that's associated with activities such as coughing, sneezing, laughing, or jumping. We know that pelvic floor physiotherapy should be the first line of treatment for stress incontinence. Okay, we know that what the research shows is that 80 to 85% success rate with pelvic floor physio without actually having to go for surgery. Okay. We also know that if women do have to go for surgery, or they decide that that's what they would like to do, that you really do want to make sure that those pelvic floor muscles are strong and have enough tone so that they can also support that surgical repair. So most people's surgeries, bladder lift surgeries, will fail just simply because those pelvic floor muscles are not functioning. Okay. We'll also see pelvic organ prolapse. Okay, so this is where that bladder or the uterus or the rectum can actually fall into that vaginal cavity. Okay, so there's quite a few women who will have a wide variety of symptoms. Actually, some women will not demonstrate any symptoms and are definitely not aware that they have this happening. So when I have any of my clients actually see their doctors for their PAPs, I actually have them, ask the doctor, because sometimes they won't disclose it, but just ask the doctor if they do actually have a pelvic organ prolapse, because we just want to make sure that that doesn't get worse. Okay, so some of the symptoms that people will report of pelvic organ prolapse includes a heaviness or a bulging of the vagina. They will have low back pain. They'll talk about bladder and bowel dysfunction and sexual dysfunction. Okay, so this is quite the slide with lots of information. As I mentioned at the start, 50% of women in the childbearing year age will have experienced some sort of pelvic organ prolapse, and there's different degrees of prolapse. Okay. Not all women, as I mentioned, will have or demonstrate symptoms. Okay, we know that symptoms are prevalent in 3 to 28% of the population. Prolapse surgeries actually outnumber stress incontinence surgeries, but by 2 to 1, and most will require reoperation. So about 30% of them will require that to be reoperated on. We know that there's lots of research to show that pelvic organ training is very effective in decreasing symptoms and the grade of prolapse. Okay, and as I'd mentioned, that there's different grades of prolapse. So there's a grade 1, 2, and 3, and pelvic floor physiotherapy, which includes strengthening of the pelvic floor muscles if indicated, addressing posture, lifestyle modifications, is kind of that first line of treatment, and that's what the research is demonstrating. Whereas grade 4 prolapse, and that's where those organs start to come out and come up to the opening of the introitus, or grade 5, which is where those organs start to exit the vagina. What happens is that typically that these prolapses will actually require surgery because we're not able to actually reverse what's happening. But we definitely know that pelvic floor training pre and post surgically would be beneficial. We also do have quite a large number of ladies who are also using pessaries for support of their organs as well. So this is another way that they can be managing their symptoms as well. Okay, so here I'm just basically showing kind of what a normal uterus, a normal anatomy would look like. So we actually have the bladder, which sits in here. We have the uterus, and then we have the rectum, and this is the vagina. Okay, This picture here basically shows that that bladder, just because of the weakening of this abdominal wall, the bladder starts to fold into the vaginal cavity. Okay, in this one here, this is where there is a rectocele, where the rectum starts to actually move into the vaginal cavity. And finally, this one here shows the uterine prolapse. So that uterus starts to descend into the vaginal cavity. Okay. I just wanted to briefly mention menopause as well. So menopause is actually just another time in a woman's life, or perimenopause and menopause, where what happens is there is a fluctuation, a big fluctuation in hormones. So our bodies start to produce less estrogen and progesterone, and these fluctuating hormones can actually influence a variety of different systems within the body. Okay, so as we get older, that fluctuating hormones can impact our cardiovascular system, so leave us prone to heart attacks. It influences our bone and skeletal system, so sometimes this is why we develop osteoporosis. It changes our metabolism. So what we notice is that we tend to start to put on weight, even if we haven't changed what we're eating and how we're moving. We can also influence our sexuality, and that it can impact, again, a decrease in our libido. And then when we think about the urinary system, with women in menopause, we can also have pelvic organ prolapse and also vaginal atrophy. Okay, so there can be a thinning of that vaginal tissue and a reduction in the motor units as we get older. Okay, so pelvic health physiotherapy is fantastic at helping to manage some of the local symptoms of menopause, which will include incontinence, pelvic organ prolapse, and pain with sex. Okay, so that next state that we're going to be talking about is the hypertonic pelvic floor muscles, right? So this is that state where those muscles can be weak, they're tight, and they're also short. Okay, so as we mentioned, some of the symptoms that you'll have is urinary urgency and frequency, where you're going to the washroom quite a bit. We'll have chronic pain states, vulvodynia, interstitial cystitis, endometriosis. We'll have urinary hesitation and retention, where you go to the washroom, you feel like you have to go, you get up, you kind of do a jig, you sit back down, and then you're able to empty some more. Okay, dyspareunia, vaginismus, and chronic constipation are all symptoms or signs and symptoms. With the hypertonicity or pelvic pain, typically, again, they're related to muscle tension and includes a sensitized nervous system. So sometimes our nervous system is that fight or flight response system. So sometimes we're consistently in that fight mode. Okay, most individuals will also have pain in their back, hips, and pelvic girdle, and it's usually related to that tension in the pelvic floor muscles. And again, that tight, weakened pelvic floor muscle, they're not able to contract as strongly in response to increases in intra-abdominal pressure. So with coughing, laughing, and sneezing, and as a result, stress urinary incontinence will occur. Okay. When we're working with people with hypertonic pelvic floors, what we find is that we really need to teach those people how to relax and lengthen those muscles before we begin to strengthen them. Okay, pelvic girdle pain is pain that is experienced in the back. Okay, so when we talk about the iliac crest, if we place our hands on the top of our hip bones, that is our iliac crest. So kind of the back side that extends below the buttock, but it can also wrap around into the groin. So this is what we classify as pelvic girdle pain. Very, very common in pregnant and postpartum women, and it's usually as a result of pelvic joint asymmetry. So sometimes we'll hear about one leg being longer than the other. We may have ligaments. Ligaments are basically tissue that holds bone to bone. And so as when we're pregnant, what happens is we develop a little bit of laxity to allow for that growing baby. We can also have ligament laxity in this area if we've ever been in car accidents or had some major trauma. Had one client who actually jumped off a roof and kind of landed on the ground. And as a result, she had stretched out some of her ligaments, much like when we sprain our ankle or go over our ankle. But in this area, very, very hard to sprain ligaments. Okay. And it can also be a result of weak and tight pelvic floor muscles. Okay, so again, in this, that pelvic floor lengthening kind of takes precedence. And then we talk a lot about glute strengthening as well. Okay. With respect to sexual function and pain, the area between the vagina and the anus is called the perineum. And we lovingly call this place the Grand Central Station. And that's because a majority or a lot of the pelvic floor muscles attach and insert in this area. And sometimes that tissue becomes very immobile. Also, if we've had children, they will usually cut into that tissue, and that scar can actually not allow that tissue to move very well, and that can contribute to pain. Okay, so usually when we have sexual function or dysfunction and pain, usually it's because that there's lots of tension within those muscles as well. Okay, with a lot of our clients who do have this dysfunction, the doctors will normally send you for a variety of different tests, like in pelvic ultrasounds, abdominal ultrasounds. They may do some blood work, but usually all of those tests come back negative. And again, it's more muscular tension that can be contributing to that. Okay, we know that 31% of most women after having their first baby will still have pain, and with sexual intercourse, usually at about 6 months. Okay, but we know that those tears and incisions are usually healed by 6 to 8 weeks. Okay, so pain after that is usually commonly related to a short, tight pelvic floor. It can also be related to changes in hormone levels as well. Okay, so when we think about postpartum periods, we really know that the pelvic floor needs to be strong enough to support the woman's body as she begins to exercise again. Okay, when you have that 6-week postpartum checkup, I really like my clients and advocate for my clients to really talk to their doctor about actually having them check their abdominal region, making sure that they don't have any rectus diastasis. We also want to make sure that they do an internal assessment where they check to make sure that that scar is healing well, that incision is moving well. Same thing if you've had a C-section as well. We want to make sure that C-section scar is moving well. You also want to make sure that have them check that your pelvic floor is working well and functioning well. Okay, usually at about that 6-week postpartum mark, I usually try to encourage my clients to come in and see us, just again so that we can make sure that your pelvic floor is functioning and that those muscles are working with all of your other muscles just before you start back to activity. Okay, just remember that activities such as running, abdominal crunches, boot camp drills, weightlifting, and Pilates, they can also increase pressure on the pelvic floor. So if that pelvic floor's function or pelvic floor muscles are not functioning appropriately, it may be that you're just not ready to go back to exercise, and you might have, you might then develop incontinence and prolapse. Okay, so what we're looking for when people come into the clinic is a minimum of a grade 3 contraction. We also need to make sure that that pelvic floor muscle is working well with your abdominals and your glutes, so that you're not having any sort of developed any sort of compensations. Okay, so when you go back to exercise, one of the things I do point out to my clients now. So back in 2019, some physiotherapists out of England or the United Kingdom produced return to run guidelines. And so they are actually free. All you actually have to do is Google those postpartum return to run guidelines. Tom Groom is one of the authors. And you can actually get that, and it's actually got some great information there. And I utilize this information not just for my clients who want to return back to running, but also for those clients who just want to exercise in general. Okay, so they go on a series of activities and exercises looking at the different weeks. Okay, so what you can do and start in week 0 to 2. And they go 12 weeks and beyond as well. And there's not even just exercise or a talk about exercising, but they also talk about energy levels. They talk about food consumption. They talk about compression garments that you can also be using as well. So very helpful. Okay. So again, a number of our clients will also come into the clinic and kind of wonder or let me know that I've been doing my Kegels. My doctor told me to do Kegels, and you know what? I've done them and they're just not working. So there's many reasons why my Kegels or pelvic floor contractions may not be working. Okay. And usually because there's not as many sensory nerves or what they call mechanoreceptors in that pelvic floor region. So sometimes there's not as good awareness. Okay. And also because we can't see those muscles. So typically, say if we're looking at our bicep, which is that muscle in the front of the arm, we can see it, we can touch it. And typically most people can't see their pelvic floor muscles, so they're just not aware of them. Okay. As we've mentioned before, sometimes there's scar tissue. So scar tissue in the vaginal area, scar tissue in the abdominal region. So when we have that scar tissue, what it does is it can actually adhere to the tissue below it. So that tissue may get stuck and then it may not move well. So what we need to do is teach you how to, or you can do this, start to get some of that scar tissue moving. That will help to allow the muscle below and the tissues below to start to contract and relax a bit more appropriately. And it also with movement as well. Okay. Another reason why people may not find that their Kegels are working is because of the presence of rectus diastasis. Okay. So rectus diastasis is where there's an opening or a gapping of the abdominal muscles. And what I want everybody to understand is that this is normal as we get older and have babies. Sorry, it's not normal as we get older. What I meant to say is that this is typical as we actually progress within our pregnancy. And it also actually becomes more common the more children that we have. Okay. So typically that gap will remain a little bit wider at about till about 6 weeks, but it should start to close. If the gap or the tension within that rectus diastasis is not created and starting to close, people may demonstrate issues with their pelvic floors. So they may start to complain of urinary incontinence. They may talk about back pain. Okay, so what we know though is that we definitely want to be creating some tension within the linea alba, which is the elastic band which sits between those two abdominal muscles, so that we can improve your abdominal function as well. So this is just a diagram here. So the linea alba is like an elastic band that kind of sits in between the rectus abdominis, and those are our six-pack abs. And what we know is that the sometimes or when we're pregnant, this definitely has to expand and to stretch to allow for accommodation of your growing baby. Okay, so again, it's definitely normal as we have babies and the more babies that we do have. The important thing to understand though is that when this tissue does get stretched out, we really need to rehab that abdominal wall as well. Okay, think about rehab when we're talking about pelvic floor and that abdominal wall as just as, if you had surgery for your knee, had an ACL tear, you would actually be into physiotherapy to actually rehab it. Same thing when you're actually, when you have a baby, just think that you've been carrying this load for 9 months. If you've had a C-section, they've cut through your abdominal muscles. So essentially what we want to do is make sure that those muscles are getting nice and strong so that they can support you throughout your life. Okay. Kegels or pelvic floor contractions are not a one size fits all. As we talked about, pelvic floor contractions should be performed in those individuals who have lengthened or weakened pelvic floor muscles, right? So as we mentioned again, it's that hypotonic muscles. Okay. Hypertonic muscles, which are those muscles that are tight and short, we want to make sure that we teach people how to lengthen those muscles before we start doing some contractions. So, we teach them how to reverse or relax their pelvic floor. Okay. We must do that pelvic floor or that internal exam just to determine what that resting tone is of the muscles. And then this also allows us to demonstrate or to really understand whether you're doing those contractions properly. Okay. We also know that we have to address some of those external tissues because those external tissues can also affect contraction. And we also need to address some of the global and lifestyle issues. So sleep, nutrition, and exercise. These are all important components to how our pelvic health is maintained. Okay, so when we talk about treatment, we talk a lot about education. So education is key here. As I just mentioned, we want to look at those lifestyle factors. We need to understand what symptoms that you're having that have brought you into the clinic. We want to understand what your goal is, right? And then what we want to do is after those that initial assessment is we want to really make sure that you understand how the bladder is functioning, any sort of behavior modification that we need to do. We need to identify any bladder irritants. And again, as I mentioned, we want to understand what your treatment goals are. We will then look to do any sort of pelvic floor training or up training or down training. We want to make sure that you understand your anatomy. The more you understand, the more you're able to connect with those muscle groups. Okay, we then want to, along with training the pelvic floor, train those outer muscles, outer unit muscles. We may have to do a bit of manual therapy where we get our hands on you if we find some stiffness in your hips, your low back, or your pelvis, or sometimes even in your mid back. And on the odd occasion, we sometimes will use electrical stimulation or biofeedback. So sometimes my clients, when we've worked together, we've kind of addressed, say, some of the soft tissue and we're working on cues to connect with the pelvic floor. Sometimes our clients just can't get that contraction. So what we sometimes will use is this biofeedback machines or electrical stim, where it actually helps to teach the clients how to contract their muscles if they're not able to do so. Okay. So just some tips as we're finishing up on some good bowel and bladder care. Sometimes our clients, because of incontinence issues, they tend not to drink. Okay. What we want to really understand is that if we're not drinking enough water and keeping ourselves hydrated, we can actually irritate our bladder, which can actually make it become a little bit more overactive. So we want to tell people to make sure that they're consuming about 6 to 8 cups of fluid or water a day, unless otherwise advised by your doctor. You want to try to spread those drinks out throughout the day. So what I normally get my clients to do is fill, a 36-ounce water bottle up that they can sip throughout the day. You want to try to cut down on sugary and caffeinated beverages. I try never to say never to caffeine, but usually what I'll recommend is that if you're having incontinence issues is, stop that caffeine or drink prior to 12 o'clock in the afternoon and try to avoid it after that time. Okay, you want to make sure that you're eating a healthy diet. So it's really important to eat lots of fiber. So lots of green leafy vegetables. And that pretty much sounds pretty consistent across the board from what we're hearing these days. We want to make sure that we're active. So we want to try to aim for 30 minutes of exercise regularly. It's about 150 minutes a week of cardiovascular exercise and 2 times a week of strength training. And those are based on the WHO guidelines. Okay, for individuals who are 18 years and over. Okay, and then we want to start to practice good toileting habits. So we want to make sure that we go to the toilet when we have that urge to go. So don't push it off. Okay, and try not to get into that habit, as I mentioned earlier, if that, go just in case. And that applies to our kids as well. And I've definitely very much a culprit at that. When we were going on those long car rides, we would tell the kids not to go or go to the washroom just in case, because we were going on that long car ride, and they'd always fight you because they didn't have to go. So like I said, trying to avoid those things, because again, we can retrain our bladder to actually start to go a bit more frequently. One of the big things we see with lots of our clients, and especially those 80s babies, I say, or those 70s babies, where we got told to kind of suck our abdominals in because it would train our abdominals and keep them in tone. Just remember that when we do suck those abdominal muscles in, we'll also increase our pressure within our pelvic floor area. And so if we increase our pressure in that pelvic floor, it can also lead to pelvic organ prolapse as well. So we want to make sure that those abdominal muscles are relaxed. Okay, so try to let those relax as you're standing, you're sitting, and same thing when you're doing your exercises. So when that core is functioning appropriately, we shouldn't actually think about sucking those muscles in. Okay. And then the final thing, because sometimes we'll get people who recommend practicing stopping the flow of urine on the toilet. So again, as I explained how that bladder works, we want to make sure that we're not practicing our pelvic floor muscle contractions on that toilet, because what happens again is that we can train that bladder to make sure contract and relax as we're going to the washroom and the pelvic floor muscle. So we want to make sure that we don't start and stop that flow of urine when really we should be teaching those muscles that they just need to relax to empty out that bladder. All right. That is our talk for tonight. Again, I do apologize for the mix-up that we had yesterday. So I hope that was informative. What I've done up on the screen is just left either our Georgetown at Aramosa email or the Acton at Aramosa email. So if any of you have any questions, feel free to send us an email. Maybe just put in a tagline, pelvic health questions regarding the webinar. Okay, so hopefully everybody had a good night. Take care.